Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello, and welcome to the Advancing Surgical Care podcast. My name is Kara Newbury. I'm the Chief Advocacy Officer of ASCA and the host of this recording. Today, I'll be talking with Chris Fox, the Executive Director of Voices for Non-Opioid Choices, also known as Voices. Voices is a nonpartisan coalition dedicated to preventing opioid addiction and abuse by advocating for increased patient and provider access to non-opioid pain management therapies. ASCA has been actively involved in supporting this mission and work for years, and it's great to have Chris on board the podcast for the first time. As a bit of background, opioids are often used for short and long-term pain management, especially for patients with injuries or postoperative pain. Opioids are a class of very strong and potentially addictive yet inexpensive drugs. Morphine, codeine, OxyContin, Percocet are some examples. Unfortunately, the same high potency and low cost availability that makes opioids so popular for these patients also presents significant risks in the form of the potential for addiction and abuse, such that we now have a huge black market of illegally manufactured opioids. Sadly, the damaging and often fatal consequences of abusing and overdosing on opioid pain medication has been described as an epidemic in the United States, claiming the lives of more than 500,000 Americans over the past 2 decades. While no part of the country has been immune to this devastating effects of illegal opioid use, the problem is significantly worse in rural areas where socioeconomic conditions, chronic health problems, and a lack of accessibility to healthcare has really devastated some communities. One response to this crisis is legislation that was enacted in 2022 titled the Non-Opioids Prevent Addiction in the Nation, or NOPAIN Act. Voices obviously led the way on this, but ASCA was very involved and strongly advocated for this legislation. And I'm going to have Chris tell us a little bit more about the NOPAIN Act and the legislation. But as all of you who have heard me speak about the ASC facility fee for some years know, facility fee typically includes drugs, biologicals, and devices. And this legislation will pull out non-opioid alternatives and help increase the reimbursement for those, making it more likely that facilities will encourage their patients to use those non-opioid choices. Of course, in 2019, the Centers for Medicare and Medicaid Services did allow for some separate payment for ASCs for certain qualifying non-opioid products, but a similar change had not been made for hospital outpatient departments. And this NOPAIN Act, in addition to expanding it to HOPDs, actually expands it for ASCs as well. So obviously, more needs to be done in this space, but this is a great first start. And with that said, I'm going to turn it over to Chris. Chris Fox is a seasoned public affairs advocate and has been the executive director of Voices for the past 7 years. During his tenure, Voices has grown into a national umbrella organization representing more than 250 state, local, and national public health organizations committed to reducing opioid abuse addiction and fatalities. With that introduction, Chris, welcome to the podcast.
Thank you so much for having me. Great to be here.
Really looking forward to this conversation, but it would be great if you could first just give a little bit of background on the origins and advocacy of the Voices organization.
Sure, I'm happy to. So we launched Voices in 2019 amidst a burgeoning opioid crisis that was claiming 130 Americans every day. Now, during the height of COVID, drug overdoses, especially those related to opioids, got to about 220 lives they were claiming every day. There's been a lot that has been reported since that time about opioid overdose deaths having come down. And it's true, they have come down from their historical highs. But as we sit here today, according to the latest data from the Centers for Disease Control and Prevention, we are still losing 130 Americans every day to an opioid-related drug overdose. So same as when we started. Despite billions of dollars that has been disseminated to states, countless efforts in terms of federal legislation. There have been 2 iterations of the Comprehensive Addiction Recovery Act, as well as 2 different iterations of the Support Act that have passed federally dedicating money to this problem. And yet, despite all of this, the problem rages on. And I would argue, and I do argue, that despite all of these efforts really focus on trying to rein in rates of opioid overdose fatalities and don't go far enough to reduce rates of opioid addiction. And that, to me, constitutes a missed opportunity. It's not to say that these efforts have been misguided or aren't helpful. They certainly are. It's a good thing that naloxone is as available in communities now as it ever has been. That's a great thing. It's a good thing that more prescribers are able to get patients the help and the care that they need now more than ever before. But I think if we have proven anything over the last decade, it has been that this is a problem that has shown itself to be resilient and one that cannot be fixed simply by throwing money at the problem. And so from us and our perspective, our origin story is about preventing opioid addiction where it starts. And for some, that can start with a prescription for opioids, because that's the standard of care today, despite all the documentaries that have been out there, is still to treat pain with prescription opioids. And the simple fact of the matter is that might work for some, but it doesn't work for everyone. And there are other options out there that patients might prefer, that clinicians might prefer, that unfortunately are inaccessible. And Voices, and my job every day, is to work to tear down those barriers that make non-addictive forms of pain management inaccessible in communities around the country.
That's great, Chris. And obviously, we strongly support what you're doing, and thank you for those efforts. We do need to take just a short pause to hear a brief message from our podcast sponsor. Stand by, and we will be right back.
This recording is being brought to you by Surgery Partners, a leading owner and operator of ambulatory surgery centers with more than 200 locations nationwide. Surgery Partners collaborates with ASC leaders and physicians to acquire, develop, and optimize surgery center operations and helps ASCs scale efficiently, strengthen performance, and drive long-term growth. To learn more, visit surgerypartners.com.
Chris, as ASCA is focused on the issue of expanding choices for postoperative pain management, why we joined with you in support of passage of the NOPAIN Act. For our listeners, could you summarize the key provisions of the Act and why allowing providers to bill Medicare for non-opioid pain approaches should be applauded?
Of course, I'm happy to. So in 2018, CMS initiated a regulatory process that would have proposed to pay separately for the use of qualifying non-opioids in the ASC setting. Voices were closely with ASCA at this point to applaud this policy change, and the rationale that the Centers for Medicare and Medicaid Services gave at the time for doing so was that they noted that the bundled payment system limited patient and provider access to non-opioids in the ASC setting. And as such, in 2019, for the first time, a separate payment was made available for procedures performed in an ASC for qualifying non-opioid products. The following year, CMS put out a proposed rule, and they did an impact assessment of what the impact of this policy change was. And they found that from 2019 to 2020, so over 1 year, there was a 120% increase in qualifying non-opioid product utilization that they attributed to this policy change. And unfortunately, at the time, CMS did not enact a similar policy change in the hospital setting, which is what the NOPAIN Act did, was it said, we're going to codify into law the change that CMS made at the ASC level, but we're also going to extend this benefit to the hospital level. And so the reason that we speak so highly of the NOPAIN Act is because it passed as prologue. And I feel like we have a fairly large pilot program that's been conducted in the ASC setting. And it passes prologue, we expect utilization of non-opioids to increase in the hospital setting in the same way that they did in the ASC. In the process, we will lessen our dependence on prescription opioids for treating acute pain and lessen the chances for individuals to misuse, abuse, or develop a newly persistent opioid problem and prevent opioid addiction before we can.
Great. I think you might have even covered some of our next question, Chris, looking at the providers and their patients' comfort level and the quality or success of the procedure they received. And what is your message to the providers about the efficacy of these non-opioid therapies compared to opioids and how patients are likely to respond to the alternative forms of pain management?
Sure. I say this with an acknowledgement that the only fancy letters after my name are FOX, no medical credentials after my name whatsoever. But all of these non-opioid products that qualify for separate reimbursement under the NOPAIN Act have been reviewed by the appropriate regulatory agency. And so these are not the Chris Fox Miracle Creams or anything like that, but these are FDA-approved products that have to be deemed safe and effective. And the comparator that most of these products use when they are going through their trials is a prescription opioid. There has been a lot of research and there's a lot of literature out there about the benefits of multimodal approaches to pain management. Oftentimes they speak, depending on the procedure, about the ability to be free of opioids, but they also sometimes speak of the need to be opioid sparing in their ability to lessen the number or potential the dosage of prescription opioids that they use simply by making these products available to patients more frequently. And so the message that I would give to clinicians and patients, especially for patients, is you're your own advocate. If you don't ask these questions, nobody's going to do it for you. And so ask questions. There are very legitimate reasons for why individuals may be postponing a medical procedure. We speak to people in long-term recovery frequently who are afraid of re-exposure to a narcotic after a surgery. And we tell them all the time that there are options that are out there and they should ask questions and be their advocate. Similarly, we know that there is an awareness gap that exists on the clinician level. Simply put, that some may have grown comfortable with the status quo of utilizing prescription opioids to manage patients. And we will even acknowledge that the majority of patients who get prescription opioids will likely be okay, but many may not want those prescription opioids because they don't like the way they make them feel. Maybe they have an individual or a loved one living under their roof with a opioid use disorder or who has misused opioids in the past, or somebody in the family that they are afraid of diverting those products into the community. There are a lot of very legitimate reasons why a patient may not want an opioid. And I think we speak to clinicians all the time. And when they evaluate procedures, I frequently hear that they are valuing most above all the return of function, not necessarily having a patient report a zero pain score, because the clinicians I speak to say all the time, it's easy to get to that zero pain score if you want to pump a patient full of opioids and put them in a hospital bed all day. However, what is more important to them is the ability for that patient to walk out of the hospital that day or that next day after having a total knee replacement, or be able to put on a dress shirt, for instance, after having a shoulder operation. So the return of function is really what the medical professionals that I speak with look for, and the ability to do that without fear of some of the consequences that can come with prescription opioids, like the opioid fog that can result in nausea, constipation, or even falls and fractures, on top of the potential even bigger risk of long-term dependence. Make non-opioids a no-brainer for a lot of people.
Absolutely. I know the list was expanded for 2026 pretty significantly, which I think is important. On a personal note, my mother had a total knee arthroplasty in 2025 and was sent home with, she used Game Ready, which is one of the ICE therapies, which was not reimbursed at the time. So she had to pay for that. But I told her if she gets her other knee done relatively quickly, that maybe that will be reimbursed for the other knee. And that brings me to my next question, which is, this is set to sunset after 2027 unless we can convince Congress to make it permanent or at least extend the benefit. Can you comment on how and when that determination will be made?
It's a very true statement. So when Congress enacted this law at the end of 2022, which went into effect on January 1st, 2025, it's a 3-year policy. And the CMS is tasked with evaluating the impact of this law. And so we're working very closely with friends at CMS to help them understand exactly what's happened as a result of this law. The legislation calls for an evaluation on resulting opioid prescribing. Take a look at someone like your mother, for example, who, if she got that non-opioid, take a look at what she may have gotten by virtue of opioids as well, and look at any changes that they can see. I think there are a number of other benefits that we're going to start seeing, up to and including reduced healthcare costs associated with the prescribing of non-opioids. We say all the time that the reason that non-opioids are not used more frequently is because the economics of non-opioids are badly misunderstood, and they are thought to be more expensive than they really are, especially if you consider the long-term consequences of an individual who may develop a opioid use pattern that can result, obviously, in overdose, dependence, addiction, or an OUD diagnosis, or even death. And for us, we have a window here to make sure that institutions are availing themselves of the benefit, that patients are asking questions about the ability to use non-opioids, to make sure that we are really realizing the full impact of this law. And then we have to make the case to our champions on Capitol Hill about what has happened, what still needs to happen. I will say 3 years is a pretty small window, and clinical practice can be slow to change. And so we're going to do our best to make sure that every clinician, every patient, and every facility knows about the availability of this separate payment for the use of non-opioids. And we take our case to CMS and to Congress to say this policy has been a wild success, and we think that it needs to continue on. And so that's our work. And we have just under 2 years left until that policy expires. And we're going to lean on our champions and lean on our coalition and lean on friends like ASCA to help us make that case about why this policy change is a good one and why we think it needs to be extended.
And some of the hurdles that I think you were raising, we have heard from some of our members that they don't fully understand how to achieve reimbursement for the codes. They are contractor price, but it's a little convoluted what you can bill. So we will be raising those concerns with CMS with the way that they outlined it in rulemaking, and probably worth following up with our Hill supporters as well. Transitioning, Chris, given all the attention and news coverage, as well as you mentioned the staggering loss of life related to opioid addiction and overdosing, it's hard to imagine that anyone is unfamiliar with the problem in the U.S. at this point, but it is also, I think, fair to say that it's a bipartisan issue. Yet despite small progress in reducing the incidence of opioid-related deaths, the Centers for Disease Control report that we can still expect more than 80,000 more deaths this year. What else besides the NOPAIN Act, in your opinion, do we need to be doing as a country, as a society, to prevent further addiction and abuse of opioids?
Sure. So I say all the time that my job at Voices for Non-Opioid Choices won't be complete until every patient in every care setting has equal access to a non-addictive pain management approach. And so the NOPAIN Act was a hugely important piece, and a piece that we hope will continue to ensuring patient access to non-opioids who are undergoing an outpatient surgical procedure. I would argue, and I sometimes do argue, that we have spent a lot of time and money and resources really focused on overdose death prevention. If you look back since the time that we declared the opioid addiction crisis a public health emergency, it's been about just less than a decade since we did so. We're still flat in terms of the number of lives that we've lost. And I think that's largely because we have neglected the opportunity to focus on prevention-based policy. The NOPAIN Act is a step in the direction of trying to focus more on prevention-based policy. But I think there are other opportunities for us to continue to focus on where individuals enter this problem. And sometimes it can be via prescription opioid pills. And for those to do better, and doing better means making available non-opioid solutions, whether that is in an outpatient surgical setting, the pharmacy counter, at your primary care office, or elsewhere, just to make sure that we are getting patients the care they need, because we are sympathetic to patients, particularly in the chronic pain community, who may see more challenges than they ever have accessing their medicines. But we also simply are pro-choice in the fact that we think patients and clinicians should have choices. Right now, for a lot of bad reasons, those choices are taken out of their hands. Now, the NOPAIN Act solved for those choices that were being made by facilities. I think we still have more work to do to make sure that insurance companies and other payers are not making healthcare decisions for patients based on short-term cost projections.
Absolutely. Chris, thank you so much for spending some time with me today. And thank you for all of your efforts with the Voices organization. Your leadership on this issue has truly been invaluable.
Thank you. I really appreciate that.
Now, before concluding, I would once again like to acknowledge the support of our podcast sponsor, Surgery Partners, a leading owner and operator of ambulatory surgery centers with more than 200 locations nationwide. Surgery Partners collaborates with ASC leaders and physicians to acquire, develop, and optimize surgery center operations and helps ASCs scale efficiently, strengthen performance, and drive long-term growth. To learn more, visit surgerypartners.com.